Anyway, moving on to subarachnoid hemorrhage. Okay, time is of the essence. So some of you already mentioned subarachnoid hemorrhage. It's a bleeding in the subarachnoid space of the brain. You could say it's very much like a hemorrhagic stroke. Okay, and this is just a very pixelated picture of what the kind of cross section of a brain is. So here's your, or maybe we should start from the outside. Here's your kind of skin. You have your skull, your vault. You have your you have your dura mater, your dura. Then you have your arachnoid mater, and then you have your subarachnoid space right there. And this is your actual cerebral cortex. So bleeding within this kind of space here, and often it's bleeding from a vessel within that space. So you have maybe an aneurysm in an artery in that space, and this aneurysm ruptures, or you can even have trauma. You get hit on the head, or you get an accident or something, and you can get bleeding into subarachnoid space. So there's various causes. We'll talk about that in a second. But just to kind of orientate you in terms of anatomy, this is where we're at. Okay. So next one. So basically causes, we talked about this just briefly. So you have trauma and you have aneurysms. Those are the two main causes. And aneurysms are linked to genetics, right? So you're usually genetically predisposed to having aneurysms. So scarily enough, I mean, there's 84 people attending this lecture. And, out of 100, there might be even one or two that have a brain aneurysm, but will go through their whole life not knowing about it. All right. So it's not like uncommon as such, but there are certain things that increase your risk factors. So things like connective tissue diseases like Ehlers-Danlos syndrome or Marfan's syndrome, those kind of things, connective tissue diseases increase your risk of having aneurysms, not only in your brain, but throughout your body. Adult polycystic kidney disease, that increases your risk of having these kind of aneurysms. And if you have a family history of brain aneurysms, then you are increased risk of having them as well, okay, for whatever genetic reason there might be. And then this kind of gives you an anatomic, this is the circle of Willis. I'm sure you guys are familiar with it. It tends to be more common in the anterior communicating artery region. And then there's other ones near the carotid arteries as well, and so on and so forth. But those are generally your causes, and you should know the risk factors, because I've met at least one or two patients that have been scanned just because they were at a high risk because their family members had died of a brain aneurysm or something like that. Okay. Signs and symptoms, right? So this is what you'll hear the patient say: worst headache of my life. Okay, it felt like I was hit by a brick, or I was hit on the head with a bat. Completely KO'd, right? So it's a sudden onset. It's often called a thunderclap headache. It's just like that. It hits you really hard, and what happens is it gets to its maximum severity almost immediately or within a few minutes. Patients often lose consciousness, so LOC, loss of consciousness. You can have some neurological features, so you might have focal neurology, so you might have like some spastic movements, you might have a seizure, often things like nausea and vomiting, photophobia, so having sensitivity to light, stiff neck, meningism, and these patients often have no previous history. So it's not like this person normally suffers from headaches or usually has a headache or sometimes has a severe headache. No, this person is normal. It's perfectly fine. He's had no symptoms, no headaches, no history of migraines, and then boom, this thing just came on, first time I ever had. So no previous history is almost always like a red flag. Like, look, you've never had this before. You've never had a headache before. Why is it all of a sudden? Could be a subarachnoid hemorrhage, right? So you got to keep an eye out for these kind of signs and symptoms. Kernig sign, again, a classic. You basically flex the hip and then you extend the knee. So basically you flex the hip here and you extend the knee. And what that does is actually stretches the spinal cord. And when you stretch the spinal cord and it irritates, the patient stops his knee from being straightened. He just stops the knee from being straightened. And that's called Kernig sign. And it's basically a sign of meningism, okay, or meningeal irritation, which, if you imagine there's a bleed within your brain, would cause meningeal irritation, okay, as would meningitis as well, because that's an infection within your brain. Again, irritation of the meningeal layers of the brain. Okay, so how would you go about getting a diagnosis? How would you go about, what investigations might you do? You would do an urgent non-contrast CT head. Okay, you do basically a non-contrast CT head is the fastest scan that you can get. So you basically send them straight to the scanner. You do an urgent non-contrast CT head. They do a CT scan, and they can tell you basically, is there a bleed or is there no bleed? That's all. That's basically what you're looking for, right? And then what you do is the other test you can do is you can do a lumbar puncture. So you can check for something called xanthochromia. Xanthochromia is a breakdown product of the blood. So whenever you bleed inside your brain, the blood cells will break down and they will release something called xanthochromia. And it looks this kind of like a yellow tingy, kind of almost like a jaundicey color fluid. And you have to wait about 12 hours before this effect actually takes place. So you can do a lumbar puncture or an LP tap in about 12 hours after the symptoms came on. And then you send it away to the lab to see if it's positive for any xanthochromia. And if it's positive, it shows that, this guy had he had a bleed inside the brain. An MRI is also very useful if the CT contrast is like suspicious but not very clear. You can do an MRI, but obviously it takes longer. And then a cerebral angiography. Again, these are much later on. You wouldn't really do these first line if you really want to confirm, or even if you want to check if sometimes this is important. Listen, all 85 of you, listen. This is important. Sometimes the patient will have an aneurysm in the brain and they will have a leak from the aneurysm, but no major bleed. So they will come in with the same thunderclap headache, very severe onset, acute, blah, 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 and then they will be fine. Okay. And so the CT head will do the scan and say, oh, there's no bleed. Okay. And because it was maybe a small leak from the aneurysm, and a non-contrast CT head will not always pick up aneurysms. So if you think, or if you're highly suspicious if this person has Marfan syndrome, you're like, okay, well, I definitely need to check if there is an aneurysm there, because we might be able to treat it before he has an actual rupture of the aneurysm. You will do a contrast CT head to see if there's an aneurysm there. So you might do that later on as a follow-up test or as an elective procedure afterwards.